So today there is a very interesting sessions on acute coronary syndrome, and we have two eminent speakers with us. Obviously, Dr. Deepak, who is a leading intensivist in Hyderabad, and with us also our staff and in charge, Sabri Apollo Main Hospital. So let's hear from them. So what's new in the diagnosis, management, and treatment of this acute coronary syndrome? And as all of us know, this is one of the important burning topic. So that is why this is a very important topic, and I want everybody and every participant to interact. And after the talk, and we'll have some questions also. So let's begin the talk. So let me first introduce Dr. Deepak. So Dr. Sonna Deepak is an intensivist in Hyderabad Health City. And basically, he is an MD internal medicine, and he has done his IDCCM from the Apollo Hospital, Chennai, and he has done his IFCCM from the Gangaram Hospital, and he has also cleared his European diploma in critical care medicine, and also he has done his MRCP from the United Kingdom. So basically, and he is currently working as an intensive care consultant in Apollo Health City, Hyderabad. He has a lot of experience. He has presented good many papers, publications, research activity. He is also trained in ACLS, the ATLS, the trauma care support, and he has also done certificate course in medicine and the law. So with this background, I welcome Dr. Deepak to this platform and enlighten us with his knowledge, with his experience, and to have throw some light on this burning topic of acute coronary syndrome. So Dr. Deepak, welcome you on the stage.
Thank you, sir. Thank you for your kind words, Gunadhar sir, and thank you, Dr. Ravi Mahajan. Sir, thank you for the opportunity. So straight away jumping into the topic, just let me just check my slides if they are visible or not. I believe they're visible, right? Okay. So today our topic of discussion would be acute coronary syndrome. As many of you know, the best way to understand a topic is to actually see the patient, learn at the bedside. The next best way to learn the topic, master any topic, is to listen to the experiences of some seniors. Again, you apply the clinical knowledge in your real practice. So today, before actually going into the subject proper, I would like to tell you two stories of two patients. So this is a patient which these two are real scenarios which you day in and day out you see. For example, you're in an ER, a previously healthy smoker presents to you with a severe chest pain. On arrival, coming to the ER, he seems to be stable. Then you have taken an ECG. It shows an ST elevation in the anterior leads. Then you send some blood workup. The cardiac markers are elevated. You've done an echo subsequently. So this is how you do the proper workup in the ER, right? All of you agree with me. So this is one setting. Maybe at 4 o'clock you see this patient. Then subsequently at 10 o'clock in the night, one young girl comes to you. Same complaints, she comes with chest pain. This time it's pricking type, 16-year-old girl. She's saying that I can see the pain here. She's pointing towards a specific point on the chest. And she says that it lasts for 2 or 3 minutes and again it goes and comes in, comes out. And according to her, obviously the pain is unbearable. The mother and father are very anxious. They're asking you what to do. So the reason why I told you both the stories are, both of the patients comes to you with the chest pain. Both are really anxious. Both attendants are asking you, what do you want to do? And what is your approach? So you agree with me, one of them is a significant chest pain or kind of cardiac chest pain, which is more suggestive. Even before you go to the cardiac markers or to the echo, you can know that this patient is at risk. The first patient is at risk. Whereas the second patient, 16-year-old girl with an atypical chest pain, most probably it's not a cardiac pain. So you want to rule in one case and rule out in one case. So subsequently, just remember both these scenarios and always imagine that you are at the bedside of the patient and understand what I'm going to say. And my objective at the end of the talk would be to make an first year intensive care student or first year a nursing student to understand the basics of the acute coronary syndrome, to at least manage a acute coronary syndrome patient at the bedside and not to do any mistakes. So as I said, among both the scenarios, how do you know which is a high index of suspicion with high probability of cardiac etiology and which is a chest pain which has low probability. As you can see from right to left, the classical signs of cardiac chest pain are central in nature. They say actually it's a squeezing or gripping kind of pain. They say in some kind of heaviness, they can feel tightness, and the pain increases on exertion. And classically it responds to a sublingual nitrate or kind of nitrates. And as the spectrum goes towards the left side, the classical feature slowly comes down. The opposite end of the spectrum is sharp pain, which is fleeting in nature, like our patient, shifting in one position to other position, disappear spontaneously and again appear spontaneously, where you actually kind of try to rule out the cardiac etiology. So as you know, depends on the risk factors of the profile of the patient. You need to understand the gravity of the situation. As the Osler famously said, you need to understand the patient rather than the disease first. Then you'll understand how to treat him, how to approach him. So as you can see, there are 4 profiles of the patient, depends on the age. One is an younger group between 18 to 44 years. You can see on the left side. Among them, the highest frequency is non-specific chest pain. Second one is the painful respiration, then subsequently abdominal pain. And you can see cardiac dysarrhythmias and those things comes a bit at the later stage, depends on the frequency. Whereas you go towards the elder age groups like middle age, upper middle age, kind of more than 80 years. Second common, first common, and third common. The first 4 causes among them, 3 of the common causes in the first 4 are more of a cardiac etiology. So the age carries a lot of weightage, and the comorbidities like diabetes, hypertension, chronic kidney disease, obesity, each of them weights to the you need to actually rule in towards the cardiac etiology when you are sending a patient from the ER to home. And these are the various differential diagnoses. As you know, the classical acute coronary syndrome patients with, you must have seen in your Harrison book, their picture, it will be seeing they'll be clutching the chest, he'll be having a lot of sweating, tachypneic. When you examining him, you may find something on the heart. This may not actually appear in many of the patients. And by the time you actually see the classical signs of murmurs or creps in the lungs, you're actually late. So other differential diagnoses are pulmonary embolism, where the patient suddenly becomes tachycardic. They may present with pain, and the signs will be less, whereas the symptoms will be more. Other important differential diagnoses are aortic dissection, esophageal rupture. So each of them, the setting gives you a clue. For example, the patient is lean, morphonoid habitus. They present with kind of piercing chest pains towards the back from the center, and there is the disproportionate pulses. Then you think about aortic dissection. Whereas the patient is a malignancy patient, cancer patient, the patient is on oral contraceptive pills, those kind of thrombotic tendencies, then you suspect a pulmonary embolism, especially the post-surgical patients. Where the patient is a alcoholic patient, retching, then you suspect an esophageal rupture. But remember, always the classical signs or symptoms may not be there. The other differential diagnoses are for the chest pain are pericarditis, myocarditis, pneumonia because of the pleuritic chest pain, pneumothorax, herpes zoster. Each of them focused elicitation of the history and focused examination will give you the lead towards the diagnosis. But always remember, acute coronary syndrome, you need to err towards the safety. If possible, if you are not sure, try to keep him in the ER for a couple of hours, repeat an ECG, get help from your senior before you send off the patients to the home. And remember this mnemonic, it's given in the latest ACC guidelines. Chest pain is more than only the pain. Chest pain is much more than simple pain. It basically denotes the underlying something gross abnormality in the vascularity of the most important part of your body, which is heart. And always try to send the high sensitivity troponin I. And early care. Time is muscle, time is life. So the early you act, early you diagnosis, then the patient will be saved. And always share the decision between the other teams. Call a senior, call an emergency register, call a cardiologist, call a critical care specialist, but make sure that you do the right step. And always the testing may not be every time. You need not go for a very high profile test every time. Most of the time the diagnosis is clinical, and always start the pathways. You know, we are a JC accredited hospital, so always you have a classical ACS pathway. Try to start it as much as possible. And remember, women and the extremes of age group may not present with the classical signs and symptoms. So try to have a high index of suspicion and try to play it safely, and identify the patients who most likely benefit from the further testing. And we'll come to that in the later part. Non-cardiac pain are now the more classical term is non-cardiac pain rather than the atypical chest pain. And structured risk assessment should always be done, and your pathways will help you. And this is a triangle which is showing to you. It always depends on the profile of the patients. If your patient is asymptomatic at a very low risk group or low risk group, then you need not go for a high profile test like angiogram, CT scans, all those things, CT coronary angio, those things. Whereas your patient is a high profile patient, very sick profile patient, like the first one which you have seen, then you need to always try to rule in the acute coronary syndrome. And whenever you have a doubt, go for a cardiac marker, repeat a serial ECG. And if there's no contraindication, go for a coronary angiogram, especially when you have a ongoing chest pain. So coming to it, broadly, the acute coronary syndromes are divided into ST elevation MI and non-ST elevation MI. The subcomponent of it is an unstable angina. Now, with the advent of high HS troponin I, most of the unstable anginas are turning out to be Hdmi. So what are the difference between both of them? Most of my subsequent talk would be focusing on the STEMI, which is most important. We need to learn more importantly, and most of it percolates to the knowledge towards the Hdmi. So remember these pictures. The reason I kept these pictures are the cardiac chest pain or STEMI or Hdmi can present with chest pain or may not present with the chest pain. As you can see, some of the diagrams will show you they simply presents with kind of epigastric pain, kind of small radiating pain in the inner side of the arms. They can present with jaw pain. They can simply present with the backache as well. And we have seen only patients getting worked up with ENT specialists just for the jaw pain, but subsequently they collapsed and subsequently it was diagnosed as an evolved MI. So remember, it has varied presentations and you should not miss it. And basic anatomy, you have an anterior circulation, you have a right side, you have a posterior circulation, right coronary artery, left circumflex artery, left anterior descending artery are the main arteries. We won't be dealing more into the anatomy. We'll come to more towards the diagnosis and the treatment in intensive care. But when you're interpreting an ECG, this anatomy will give you an idea and give you an edge, right? So how do you diagnose an MI? STEMI especially, you always try to group the ECG leads. For example, your V1, V2, V3 till V3, maybe they'll give you an septal leads, whereas your anterior leads are V1 to V6. And inferior leads are 2, 3 AVF. Anterolateral, anteroseptal, they can also may show you underlying circulation. The reason you need to remember is when you find something abnormal in these leads, try to look for the other leads in the same spectrum. For example, you find an abnormality in the lead 1. What will you reflexively do? You need to look into the AVL and V4, V6. Then if the same ST elevation is there, then you look for the reciprocal ST depression in the opposite leads, right? I hope I'm clear till here. So this is another picture, the echocardiographic pictorial representation. So the reason I kept is to give you an idea of basically that each part of the heart is supplied by specific circulation. For example, there's a LAD circulation for if your LAD is blocked, then you will find a regional valve motion abnormality in the specific those bases of the heart and the 2D echo. Whereas that same corresponds to the other arteries like right coronary artery, LCX. So when you're looking at it, you need to always think in your mind, I'm finding an abnormality here, I'm finding the wall is not moving here, or maybe ECG abnormality in this particular distribution. So my culprit artery would be the specific one. For example, I'm finding in an LAD territory, that is septal leads. You need to think that when I'm going to an angio, I'm trying to look at the LAD. Right? We're clear till here. So we understood what are the abnormalities which you can find on the ECG, how to look at each reciprocal leads and the same distribution leads. Now we need to understand, especially we are talking about intensive care, each patient is different. Your classical patient, like the first patient we have seen, it comes to the ER with the chest pain, smoker, diabetic, those kind of same presentation, then it is easy to diagnose. As long as you're quick in your feet and you're thinking, then you need to diagnose that patient. That is type 1 MI, where because of the underlying issues, the plaque, the atherosclerotic plaque blocks the coronaries and it causes a spontaneous myocardial infarction. Whereas it may not be classical always. There is a type 2 MI, for example, you have a sepsis patient with severe critical illness on the ventilator, then the demand is more where the supply will be less from the heart. The coronaries will be previously, there may be narrowed. That is called as type 2 MI. Whereas type 3 MI is sudden unexplained cardiac death. Type 4 MI and type 4 MI are more related to the post-cath lab procedures. There the MI is secondary to the procedure. Type 5 MI is secondary to the bypass. The reason I'm telling is you need to understand the pathophysiology behind each of them. Just see the picture there. There are three pictures here. So the first one is the normal one, whereas the second one, there's a atherosclerotic plaque. You can see that yellowish one is the fat deposit underlying the intima, where something happens, suddenly the plaque gets rupture, that becomes a prothrombotic area. Then the platelets comes to there, then it occludes the entire vessel. So what are the, now you understood what are the things we go on is, we've seen the ECGs, which arteries you need to look, how to look at the 2D echo. Then you know the basic coronaries, what happens at the coronaries level. Now you right coming to the first patient, you are at the ER, you saw the first patient, you are seeing at the ECG. How to diagnose an ST-MI? It's a pretty simple thing. Every one of us need to know ST elevation at the J point in 2 contiguous leads and more than 1 mm in all leads, except in V2, V3, where the cutoff would be more than 2 millimeters. And if it's a female, the cutoff would be more than 1.5 millimeters. If you see it, and in the proper setting, it is an ST-MI. And remember always, when you have a left bundle branch block in your ECG, always try to look at the previous ECGs. If it's a new onset bundle branch block, you need to think about the ischemia. Pathological QAs may be there when the patient is already comes to you in a later presentation, evolved MI. NSTEMI, there won't be ST elevation, but there will be an ST depression. But remember, for all practical purposes, NSTEMI is equally dangerous and compared to STEMI. And these are the various ECG findings which you can see in the acute MI. Right from the first one where you see a hyperacute T wave when the patient presents very early, you can see a tombstone appearance, you can see pathological Q waves. Ultimately, maybe once the patient comes to you pretty late, you can see an evolved MI. And these are simple things. When the patient has a pre-existing LBPV, how to diagnose? We won't go into the details of it, but remember there is something called as concordant ST elevation and discordant ST segment elevation. Maybe at a deeper class level we can discuss, but it would be more than 1 millimeters in concordance and more than 5 millimeters in discordance. And what are the false positives? As we have seen in the second slide or third slide, a lot of other mimics will be there for the chest pain, but the setting will give you an idea. And remember always the acute coronary syndrome in the 5HT and 5T in the ACLS pathway, you need to always rule in. And false negatives, this is more important for me. Always remember myocardial infarction may not have a classical ECG, and it sometimes almost up to 20%, you may have a normal ECG. But with the right experience and right index of suspicion, you need to repeat the ECG and you need to see the serial ECGs and cardiac markers. Coming to the cardiac markers, how does it help you? As I told you, the more newer definitions of MI has a lot of importance towards the cardiac markers. Among the cardiac markers, I think we routinely know about something called as high sensitivity troponin I. There are other cardiac markers as well. Some of them raises too early, like myoglobin, CKMB, they raise very early, but they are not specific. For example, you may have a lot of muscle damage. The persons who has a associated skeletal muscle damage, it may be insensitive. Myoglobin also rises fastly, but again comes down fastly. You may miss it. But for us in the practical setting, the troponin I, HS troponin I is very useful, and it detects in early. but it may require at least 6 hours to detect the myocardial damage. But the good thing is you can detect it for longer durations of time as well. As you can see, troponin I, the peak reaches at 18 to 24 hours, but the duration will be up to 10 days. So that actually, sometimes it may be problematic where the troponin values will be detectable after a long time as well after the initial insult. So the clinical decision matters here. So this would be a repetition where you're seeing the other differential diagnosis for raised cardiac troponin I, any renal failure, sepsis, aortic dissection, burns, those things also can cause a high troponin I. And coming to the management proper, remember, time is muscle. Each minute is very crucial. You're losing the muscle. The muscle here is the cardiac muscle, which is very vital. The pump which maintains the entire body is the heart. If you're losing each muscle filament in this heart, then you're losing the life. So basics of treatment would be, what are the basics of treatment? You diagnose as early as possible. The guideline says right from the patient enters into your door, the time which need to be taken for the ECG and to diagnose it as an ST elevation MI should be as less as possible and less than 10 minutes as much as possible, and should never cross 10 minutes. And once you suspect it, you have various treatment modalities. There is a pharmacological treatment, there is a non-pharmacological treatment. Non-pharmacological treatment is reassuring the patient, identifying the vital, identifying the alarm signs, maybe starting an oxygen, connecting start a good IV cannula. Always try to secure 2 wide bore cannulas. You never know when the patient crashes. Connect an ECG monitor, anticipate the arrhythmias. These are all non-pharmacological measures. I think Ms. Shabari will be discussing in the later part these things. Pharmacological measures are antiplatelets, anticoagulants, fibrinolytics, and in a PCA acute hospital, go for a percutaneous coronary intervention. And as soon as possible, as fast as possible is the strategy for you. This is the basic diagram where once you do all these kind of things, anticipate for the complications. In the last, we will be brushing it up. So as you can see, first medical contact to the ECG and interpretation of the ST elevation MI should be less than 10 minutes, and quickly determine whether it's a PCA, PCS, and PCA is basically where you have a cath lab and you're able to do a percutaneous coronary intervention or PTCA. So always try to keep the limit. The standard of care is it should be less than 120 minutes. If your center is PCA accredited center, for example, you have a cath lab, the time for the entrance of the patient, diagnosis, and revascularization in the cath lab should be as low as possible. 60 minutes is the standard of care. If your center is not having a cath lab, what do? Quickly determine whether you can send the patient to a cath lab accredited hospital or not, where you have a proper cardiologist who can do a PTCA. If you can do it within 120 minutes, then give initial antiplatelets, start the initial treatment and send him, and make sure that PCA will be done as quickly as possible. If you cannot do it within 120 minutes, then fibrinolysis is the standard of care, and your initial fibrinolysis, the bolus dose of fibrinolysis should be given less than 10 minutes. So this is the strategy clock, right? This is what I told you. Quickly determine whether you have a cath lab or not, whether you can do a PCA or not. If you can't do it, then give a bolus of fibrinolytic. It doesn't matter whichever the best one, fibrin specific one, tenecteplase, altiplase, whatever it is, you try to give it as fast as possible. Once you do it, then you decide whether to transfer it to the PCA center. Try to make it as quickly as possible, maybe 90 minutes. And once you do it, stabilize the patient, within next 2 to 24 hours, you need to decide whether to go for a PCIA or not. So these are all, I won't be wasting too much time on it, but the basic take home point of this slide is up to 12 hours after the initial chest pain, you have some window period where you can still go for a cath lab procedure, PCA, and reperfusion therapy through the revasculation can be done. And primary, you need to learn sometimes called as primary PCI, rescue PCI, salvage PCI, these things. Primary PCI is the first setting where where you have a cath lab directly go within 60 minutes. Whereas rescue PCI is when you've done a fibrinolysis, but your chest pain is not coming down, then you go for a rescue PCI. And when is the absolute, always remember PCI is always better than the fibrinolysis. And especially when you have a hemodynamic instability, when the patient is in shock, when the chest pain is not responding to the treatment, medical treatment, when you have a refractory arrhythmias, when your blood pressure is dropping, then the PCI is the definitive one. So summary of the important time targets, as I told you, it would be we will be revising in the last. So how to improve it? How to improve the times, these times which you know. So when the patient, this telehealth helps here. When the patient goes to you, when the paramedics goes to your home of the patient, try to send the ECG in the ambulance itself to you. You can interpret it and you can cut short the 10 minutes here. And always the availability of on-house or in-house cardiologist helps you. Set up at a PCI capable hospital, what do you want to do? So quickly determine there's an indication. There are no major contraindication for primary PCI, and always prefer for a radial route rather than the femoral route. This is, I think we have discussed this. So among the radial route and the femoral route, the radial has the less complications. Try to avoid too much of contrast and try to avoid the dehydration, because it may induce your contrast-induced nephropathy. What are the adjunctive antithrombotics? You have a lot of adjunctives like antiplatelets. We'll be discussing it. Always try to give a good loading dose of antiplatelets. GP2B3A like F6 these kind of things. No, these are applicable in specific situations, not in every situation. Anticoagulant therapy, heparins, we'll be discussing. So just 1 or 2 slides on this. Always try to give a loading dose of aspirin. 325 mg is what we practice here, and continue for a maintenance dose. The other agents like clopidogrel, prasugrel, or ticagrelor depends on the setting, depends on the risk of the atherosclerosis. So at our place, you either choose a clopidogrel or ticagrelor, and the duration of the therapies depends on your drug-eluting stent or bare metal stent. And usually we practice at least for 1 year, the combination dual antiplatelet therapy. And as I told you, abscesmac, tirofiban, eptidfab, these are in special situations where you know that there is something called as high thrombotic burden, when we'll keep the infusion of these medicines and try to soften the clots. Anticoagulants, heparin is the standard of care. Unfractionated heparin, we either keep it as an infusion or as a bolus doses, and we'll target an ACT or APTT. And what do you do when you have an heparin-induced thrombocytopenia? Go for an alternative agent like bivalirudin. Fondaparinux is not actually approved, and it's a class 3 recommendation. And the non-PCI capable, as you all know, the reperfusion is your strategy. You cannot waste too much time in the transport as well. So quickly rule out the contraindications for fibrinolysis, like absolute contraindications like active bleeding, intracranial aneurysms, recent neurosurgeries, all the active aortic dissection, those kind of things. But relative contraindications, try to weigh in whether the risk or benefit is more for you. And when you think that the contraindication is flimsy, try to always go for an aggressive measure, try to salvage your muscle. The timing of fibrinolytic therapy, we know 10 minutes. Choice of agent, always the fibrin specific agent. Tenecteplase is the best agent which is available. In a peripheries, maybe streptokinase is also acceptable, but I think more and more we are discouraging it. How do you know that your reperfusion has worked or not? For example, you give a tenecteplase. How do you know whether it's working or not? Because you need to go for a rescue PCI if it doesn't work. So it is both clinical, ECG, and marker. Markers are not that useful. For example, the patient is feeling better. You can actually visibly see the lessening of the chest discomfort. The STS segment elevation comes down by 50%. So reperfusion arrhythmias are actually indicates the good perfusion to the heart. This indicates that your fibrinolysis worked for you. If not, then you need to think about rescue PCI. Aspirin, we have seen it. Anticoagulant therapy, we have seen it. No need to remember these doses. Just remember the pathophysiology and the side effects where you need not give it. This would be oxygen. Quickly, don't keep on starting each acute coronary syndrome patient on oxygen, because the harm is equally important with the rather than the benefit here. So anything above 90 to 92% saturation is good enough for you as long as the patient is comfortable. Try to aim more for the other treatments. Beta blockers has a high beneficial value, and long-term mortality is there. And IV beta blockers are discouraged rather than the oral beta blockers, and should be started as soon as possible within first 24 hours. And only contraindications are the only caution you need to think about is especially when you have a right-sided MIs or inferior wall MIs where you have associated conduction blocks, where the chance of like advancement of the conduction block and going into complete heart block is more. And renin-angiotensin system inhibitors, you are talking about ACE inhibitors and ARBs here. So they have a mortality benefit, should always be administered, especially the evidence is more in the patients who had a low ejection fraction less than 40%. And if you cannot give it within 24 hours, maybe ARBs also can be considered. Nitrates, definitely there may not be a definitive mortality benefit, but we all know they form a standard of care. So it reduces the myocardial oxygen demand. It increases the subendothelial perfusion. So it develops the coronary collateral blood flow. So you can choose your oral nitrate or IV nitrate based on your severity of the chest pain. The settings where you need to be cautious is low systolic blood pressure, again in the right heart infarction, because right heart is dependent on the preload, and your nitrates decreases the preload. Calcium channel blockers, there is no mortality benefits. Statins, statins form an integral part of the management of acute coronary syndromes, especially when your LDL cholesterols are even 70 milligrams deciliter. So now that thinking is more and more towards the high doses of statins. So remember the contraindications as well. Analgesics, however much the patient complains of pain, morphines are the crux of the treatment around which the pain control revolves around. Try to avoid NSAIDs, try to avoid corticosteroids for the pain control. So you know the rescue PCI, once you know that these things are there, patients' hemodynamics are collapsing, chest pain is continuing, ECG no resolution, then you go for a rescue PCI. Once you know you've done your bit, you've given a fibrinolysis or you've done a cath lab procedure, maybe PCI, given an antiplatelet, stabilize the patient in the cardiac ICU. Now, what are the things you're anticipating? So remember, there are always complications, and your ability in management of complication lies in predicting the complication and identify the complication at the earliest stage. So post-infarct ischemia. Post-infarction ischemia is basically when you need to go for a procedure post-fibrinolysis. And remember, the left main disease, multiple vessel disease are the places where you need to go for a definitive CABG rather than attempting for the PTCA. Cardiogenic shock is one of the major complications. In fact, one of the most common complications we see, and IABP may help you here. And the LVAD, it depends on LVAD or VAD. It depends on your setting. You can use an left ventricular assist devices as well. Heart failure is one of the most common complications after STEMI, and it carries a very poor prognosis. You need to quickly identify which type of Phillips classification. And BiPAP may help you, diuretics may help you along with your nitrates and ongoing antiplatelets. Ventricular free wall rupture, acute ventricular septal rupture, these are major mechanical complications, and they have a very poor prognosis and very high mortality rate. And that's the reason I told you should not use an NSAID or corticosteroids, so that increase the frequency of it. The same thing. Acute MR is again one which is very common we see, and you need to know the timing. It may occur initially within 24 hours or maybe later bimodal, later on at the 3 to 7 days. Any patient who suddenly presents a pulmonary edema, who was reasonably stable, suddenly presents with a pulmonary edema or hypotension or cardiogenic shock, try to get an immediate 2D echo, see the papillary muscle rupture and mechanical complications. RV infarction is one thing. When you see that the signs are less and the symptoms are more, and the patient has an associated right-sided SETC changes, The reason why it is very underdiagnosed is because we routinely don't keep the leads on the right side of the chest. So V4R, it is a very good practice to start keeping the right precordial lead as well, which is the most sensitive ECG marker. Especially when you have an inferior lead, inferior MI or posterior MI, RVMI is also very common. Pericarditis is pretty common, but it is most of the times it can be resolved. Ventricular arrhythmias is, in fact, in the yesterday night itself also we have seen refractory ventricular arrhythmias, whether it may be a VT or VF, they're very common after the ischemia. Early reperfusion comes to like decrease the incidence of ventricular arrhythmias. When you have a refractory ventricular arrhythmias, always think that whether there may be a stent, new onset stent thrombosis, or maybe the vessel may not have opened. Maybe you need to go for a rescue PCI again, or maybe defibrillator. ICD therapy, any patient who presents with a ventricular arrhythmias, before you discharge this patient, always try to assess, maybe you need to keep an intracardiac defibrillator. And always once you discharge the patient as well, I always again try to call him to the follow-up clinics, get a Holter and see for the need for ICD. Bradycardias, bradyarrhythmias are very common in the inferior, posterior and right heart infarctions. Most of them are self-limiting, but maybe you need a atropine or TPI to bridge that period. But remember, if you have a bradyarrhythmias in an anterval MI, that's a very poor sign, because you know the conduction system is, most of it is supplied by the right coronaries, which is anticipated bradyarrhythmias. But if you have a bradyarrhythmias in your anterval or lateral MI, that indicates extensive damage and very poor prognosis. Once you've done your job, you tide over this crisis, your patient is free of complications. What do you want to do? You're shifting these patients to the ward. Ms. Chabri will be discussing what are the things you need to see. But risk assessment is very important. Early assessment within 3 days and later assessment more than 5 days. And again, after 2 to 3 weeks, you need to assess the patients for the risk and see for the complications. Sudden cardiac death is very common, and it would be very painful to see a patient who you rescued with the timely management. The attendant comes after 1 week and tells you he had expired at home. That is pretty painful to need to follow it up. Post-hospitalization care, smoking cessation, lifestyle modification, cardiac rehabilitations, you need to remember that history begets history. Any patient who had an acute cardiac event, it indicates something major problem with his vessels. Atherosclerotic disease is very high. So think that this patient is at risk of further events as well. So you need to counsel him. Cardiac rehabilitation is a very important thing. So this is the last slide, very important slide. Why your time is very important is, if you don't break this cycle, the progressive myocardial dysfunction will be there, and ultimately early or delayed death is very common. So again, I cannot reiterate more and more. Time is muscle and time is life. So this is my favorite quote. Every battle is won before it is actually fought. If you know what to look for, if you know what to manage, you know how to manage, then most of your war here is management of the patient and seeing a happy patient going home. You have won it. Thank you for your patience.
Yeah, thank you, Dr. Deepak. I think it's an excellent presentation. The message is very clear. And just in a nutshell, as all of us know now, just in a simplified way, if we talk, basically the management has changed from something called as MONA, like morphine, oxygen, nitroglycerin, and aspirin. And now the oxygen part is out. In most of the cases, we don't give oxygen if the saturation is more than 94%. To a more simplified term, if we see the NICE guidelines of 2020, they have simplified it in the form of what is called as mnemonic called as DRAMA, like the dual antiplatelet, the reperfusion therapy, the analgesia, the maintenance dose of oxygen, and something called as antithrombotic therapy. So thanks again, and I think we'll take the questions later on. Now we will invite our second speaker. She is Sabri, and she is quite expertise in managing the cardiac cases. Basically, she has done her MSc in graduate in medical surgical nursing from Apollo College of Nursing, Vanagram, and working in Apollo Main Hospital as a quality nurse in Apollo family with us since 2016. And from March 2016 to September 2021, she has worked as a shift coordinator in the Apollo Intensive Cardiac Care. So let's hear from her what are the emergencies management of the acute coronary syndrome as a bedside nurse, and what are you are supposed to do. So I welcome Sabri. Please start your talk. Thank you.
Namaste, sir. Thank you for your kind words, and namaste to everyone. I thank everyone for giving this wonderful opportunity to meet with all and present about the nursing care, which is essential to be given for the bedside patient who is under ACS. I'll share my slide. So I'll be discussing about the nursing care of patient with acute coronary syndrome. My slides and my presentation will be basically on 3 types. First, the care which has to be provided in the emergency department, and next, after the coronary angiogram or coronary angioplasty, the care they should be given, and at last, if the patient has undergone CEBG, what are the care should be given. So first, let me discuss about the care of patient with acute coronary syndrome in emergency department. As sir has said, Dr. Deepak has said, time is muscle and muscle is life. So the immediate concern for a patient with a myocardial infarction should be, first, we have to promote their safety and also their comfort. Intravenous access should be done immediately for the effective administration of emergency drug, because we don't know when the patient may go to sudden cardiac arrest. So intravenous access is very essential. And the next is the assessment and the treatment should not be delayed, because medical emergency in ACS is where the minutes. So the assessment and treatment, it should not be delayed, and the medical emergency is where the minutes can make the difference. So rapid movement. So care of patient with acute coronary syndrome in emergency department is first is the providing oxygen to prevent the arterial hypoxemia, and second one is the analgesia, which is the powerful analgesic, and also it will help in the anxiolytic to reduce the anxiety of the patient. Antiemetic will be provided to reduce the nausea and the vomiting, which is developing due to the opioid analgesia, which is administered to the patient. For example, if you are going to administer morphine to the patient, it is necessary that the antiemetic should be administered to the patient. And then administration of nitrates is essential, which will reduce the myocardial workload and the myocardial oxygen demand by reducing the preload and the afterload. So immediate measures which should be done to salvage the threatened myocardium is, first is the early recanalization of thrombolyzed coronary artery. Because if we don't recanalize the thrombolyzed coronary artery, it may lead to ischemic myocardium. So first should be our aim, or the target or the aim of the treatment should be the recanalization of the thrombolyzed coronary artery, which can be done in 3 ways. First is the aspirin. Aspirin has the antiplatelet effect, and it should be avoided in recent GI bleeding and in the intracranial hemorrhage bleeding. So other than that, the aspirin can be administered. And second one is the thrombolysis or the fibrinolytic therapy, which Dr. Deepak has explained earlier. So we have 3 types of treatment: aspirin, thrombolysis, and coronary angioplasty. Thrombolysis is lysing the infarct artery thrombi and achieving the reperfusion. Thereby, it will reduce the infarct size and also preserve the left ventricular function, and it will improve the survival of the patient. The most effective thrombolytic regimens, it achieve the angiographic epicardial infarct, which is patency only in lesser than 50% of the patients within 90 minutes. And next is the management is the coronary angioplasty. So coronary angioplasty, it may in case of ACS, STEMI or NSTEMI, the first choice of will be the coronary angiogram, which is followed by coronary angioplasty or the CABG, depending upon the lesions of the patient's coronary arteries. So next is the nursing assessment. The nursing assessment or the manifestations are, first is the appearance.
So in the meantime, can we have some discussion or any queries or anything from the audience side from the talk of Dr. Deepak, so that we can discuss in this 5 to 10 minutes if there is time? So anybody from the audience, if any questions, we can able to answer it or discuss it with you. Okay, I think so. There is no question. So I have just one or two means doubts and a few of you. I want to know a few of your experience, Dr. Deepak, if you can share. Like one is my question is nowadays we are getting a lot of COVID positive patients, and the incidence of myocardial infarction is quite high among such patients because nowadays we are seeing almost majority of the patients has elevated D dimer, and most of them young patients also coming with some kind of thrombosis, and the coronary and pulmonary thrombosis are very very common. So what is your experience in your center, and what are your protocols for such patients, the early thrombolysis versus your angioplasties? So what is your experience, can you share?
Yes, sir. Yes. Sir. So as you rightly said, I think we are living in an era where almost every other person is a COVID patient. For me, I think there are only two categories: either you're positive or you haven't tested yourself. So now we have seen two kind of people. One thing is an elective patients, where the patient comes to with a classic chest pain kind of acute coronary syndrome, but unfortunately he tested positive. Then we are trying to reassess the patient whether it's an elective procedure, urgent or emergency. If we are very sure that it's an urgent or emergency procedure, then we are following the COVID protocol. In the cath lab, there is a specified place, or one set two, we have 3 or 4 cath labs, so one of them is specified for it. Then we are going ahead with the PCI. Still, the PCI remains the standard of care. Rest of the treatment is the same thing. But as you rightly said, they're more prothrombotic than the other patients. We need to watch for the like restenosis, those kind of things again. Second thing is patients admitted with a severe COVID, they develop a type 2 MI in an ID COVID ICU or some kind of things. Then the things are pretty difficult, sir. The patient will be a BiPAP, they'll be generating a lot of aerosols. Most of the times we're trying to go with a conservative approach where we are trying to give a fibrinolysis. But if you're really at heart, we know that the PCI is the one which actually salvages it. Then we are going with the same protocol. But most of the patients are actually demand type MI, where if you control the severe COVID, the air hunger, those kind of things, the perfusion also improves.
Correct. I think it's quite a standard of care, I think. And second thing is, can you just in nutshell let us know what is your this thing protocol for the dual antiplatelet therapy like aspirin and the clopidogrel? Because nowadays the majority of the focus is shifting from the clopidogrel to the newer antiplatelets like ticagrelor and prasugrel. So
Correct.
what is your experience on that? Can you share?
Yes, sir. For us, the aspirin is the backbone. So for every patient, aspirin will be kept. Among the other agents, most of us actually we are using with a clopidogrel as well. But if there's a high risk lesion, then we are thinking about ticagrelor, where the patient already has a previous PTCA, they presents with a kind of new vessel, ticagrelor, but bleeding risk is equally high, sir. Prasugrel, especially the patient is elderly, the bleeding risk is really high. So we need to really think whether it's indicated or not. But if you have a recurrent MI, recurrent stenosis and all, maybe these agents are more choice. The duration is 1 year minimum for us, sir.
Okay. And what is your this post PCI your protocol like the standard of care like in the beta blocker in terms of AC inhibitors and in terms of diuretics and the statins? So how do you keep this balanced on these drugs in a patient who has undergone angioplasty?
A standard protocol, sir. For every patient, we'll give a loading dose of antiplatelets in the initial part. Once we're done a PCI, then they'll be coming back to the cath lab, CICU, cardiac ICU. Then they'll be starting after maybe 6 hours or something. They'll be obviously giving a loading dose of heparins in the cath lab. Then subsequently, they'll be starting on a regular dose. So enoxaparin or unfractionated heparin, both are equal to us. Enoxaparin is much simpler and equal efficacy. But if the patient has a more bleeding risk, a chance of going back to the cath lab more, we're trying to keep an infusion where we can titrate it, maybe try to stop it as the reversal will be easy for the unfractionated heparins. Fondaparinux, we really don't use and the evidence is pretty less. And one other thing you asked, the diuretics and all classical management of the congestive heart failure, whether it's a furosemide or torsemide. Nitrates, so it's pretty useful in the clinical practice, actually. We use it. levosmendan and those things we hardly find much benefit, sir. Newer drugs like triple drugs you have, we have polypill is the standard of care now. Try to keep an ecosprin gold rather than separately.
Right. So I think if the slides are ready, can we go ahead with the presentation before taking some few questions after that?
Yes, please. Yes.
Okay,
Yes, sir. The slides are ready.
Yeah, thank you.
Okay. So next we are moving to the nursing assessment of manifestations which should be done in emergency. First, the appearance of the patient should be noted. It may be anxious, restless, pallor, and diaphoresis. And then the blood pressure and the pulses of the patient should be documented. Breathing, the jugular vein distensions, auscultation of the heart and lung. We have to auscultate whether any abnormal heart sounds are here, like S3 and S4. The shortness of the breath, which we called as orthopnea, should be noted. The chest discomfort should be monitored. It may be pleuritic or point tenderness, or it may be localized or diffuse. And we have to assess whether the patient is having any palpitation. So nurse, next is the diagnostic test which should be done in emergency department to find out the MI. Well-lead ECG, the chest X-ray is done to assess the cardiac size and is there any pulmonary congestion is there. To assess the pulmonary congestion or the patient has developed pulmonary edema, the chest X-ray is done. And next is the stress test on a treadmill with the electrocardiogram and also with BP monitor. So next is the blood test, which are the enzymatic tests which is done, CPK-MB and troponin. So a ER nurse should be aware when the CPK-MB or the enzyme test will be rise, when it will be peak, and how many hours or days it will be elevated. So CPK-MB will be rise in 4 to 8 hours and it will be peak for 12 to 24 hours and it will be remain elevated for 1 day. Whereas troponin, it will be rising in 3 hours and peak for 12 to 18 hours and it will be remain elevated up to 14 days. So next we are moving to the nursing intervention which should be done in the emergency department. Depending on the plan of care for the patient, the nursing intervention, it will differ. If it is medical management, the nursing interventions are different. When the patient is in, we are giving thrombolysis or fibrinolysis, the nursing care will be entirely different, and post PTCA and angio or post CABG, the care will be different. So first, aspirin. Whether when the doctor advises of loading the patient with aspirin, statin, and clopidogrel, we should be aware why the medicines are given to the patient, and the family education about the medicines also should be explained to the patient. So we should assess the history of previous GI bleeding, intracranial hemorrhage, and we should know that the correct dose of antiplatelets are administered as loading dose for the patient with MI. And second one is the thrombolysis or the fibrinolysis therapy. So it is the mandatory that the doctor should get consent from the patient and patient relatives, which should contain the benefit, the cost, and also the complications of thrombolysis. Once the loading dose or the start dose of thrombolysis is started, we should advise bed rest. We should advise monitor the vital signs every hourly, which should have including the GCS, because the patient may develop stroke after the administration of thrombolysis in rare cases. So as a nurse, it is our responsibility to assess the early symptoms of stroke. So GCS to be done every 15 minutes or every after half an hour, depending upon the patient, and pupil size to be assessed to know any intracranial bleeding. It is essential that we should measure the INR or PTT, prothrombin time, every 3 to 4 hours after the thrombolytic infusion, which will confirm the activation of fibrinolytic system. And we have to perform only essential ABG or any blood samples if it is necessary. And after taking the sample, the manual pressure should be provided at least for 30 minutes. So depending on the plan of care, next we are moving to primary coronary angiogram. If the patient is posted for primary angio, we should note that the patient is on NBM, that is nearby mouth, chin to toe preparation is done, because we don't know whether it's going to be performed in radial or in the femoral side. So chin to toe preparation to be done, and we have to ensure whether the doctor has received the consent. Depending upon the angio findings, the plan of care will be medical management or primary coronary angioplasty, or it may be CABG. So for medical management, we have the B-carb score as a mnemonic. First is the bed rest, ECG monitoring. We should give emotional support to the patient. We should cluster the patient care, anti-embolism stockings, bedside commode should be given for the patient, stool softeners, they do not strain themselves, and then cardiac rehabilitation program, oxygen therapy, range of motion exercises to prevent the DVT, and we have to educate and inform. Next, I'm going to explain the nursing intervention which should be done after the coronary angiogram or after the primary PTCA. So before the patient returns to the unit from the cath lab to the cardiac CCU or the cardiac ward, the nurse should ensure that all the equipment is available to evaluate. The equipments may be monitoring of a monitor should be available, monitoring of the blood pressure and the vital signs should be available, and it is essential that we have to assess the bleeding of the patient from the site of prick. It may be femoral or radial. We can monitor the HB if there is many bleeding, and hematoma. So any ooze, any swelling, any hardness is present. It should be assessed every 15 minutes for the first 1 hour and followed by every half an hour for the next 2 hours. So next is the infection. We can assess it by the fever or the increased WBC count. So we have a method called transradial band. For some patients after the coronary angiogram and coronary angioplasty, after the removal of the sheath, they can apply a dressing, mainly with Dynaplast dressing. And nowadays, transradial band is very familiar, used by the doctors for the puncture site. So the pre-post procedure orders and post-care policy to be maintained. Place the PP cuff on the non-procedure arm to assess the BP of the patient. It should not be used on the procedure site. Place oxygen saturation probe on the procedure site thumb or index finger. This is done to ensure the oxygen saturation of the level through the puncture site. It will be helpful. It will be accurate. Support procedure arm on a pillow with the palm face up. Encourage the patient to restrict moving or using the procedure hand or arm for at least for 6 hours to prevent the ooze and the bleeding. Call the doctor with consent if there is any change in sensation, any change in the motion or circulation in hand, any bleeding, oozing, swelling. These should be considered as immediate and it should be taken action. Next, for all the patients who are undergone angiogram or angioplasty, these are the nursing intervention to be done. Monitor the vitals, GCS and electrocardiogram. Once the patient has completed primary coronary angioplasty, ECG to be taken to see whether the ST elevation is reduced. Bed rest for 6 to 8 hours. So every patient after the coronary angioplasty, they will be 24 hours in the ICUs to monitor the vitals, and any arrhythmias is there. So they will be completely in the ICUs with the bed rest. Assess the puncture site and pedal pulses. It is essential that the patient should be hydrated well, because while doing coronary angioplasty, dye will be administered to the patient, which may affect the kidney of the patient and it can increase in the creatinine level. So we have to hydrate the patient very well in order to elimination of the dye can happen through the elimination of the urine. And exercise and dietary pattern. It is essential that we should provide the dietitian advice to the patient in order to follow when they are going to discharge. And during in the cath lab, if the patient has developed any LBB or RBB, which is MA associated with the heart block, the procedure can be done with temporary pacemaker, or the patient may need permanent pacemaker implantation depending upon the patient's condition and which vessel is affected. So it is essential that the nurse should be aware of taking care of the patient with the permanent pacemaker implantation. So pacemaker is a device that sends the small electrical impulses to the heart muscle, which will maintain the suitable heart rate, and it will also stimulate the lower chambers of the heart. So a pacemaker, it may be used to treat syncope, congestive cardiac failure, or the hypertrophic cardiomyopathy. So in case of pacemaker implantation, it is essential to monitor the vital and GCS, complete bed rest for 12 hours, and we should not give heparin for the first 48 hours, which may lead to the oozing site of the permanent pacemaker implantation. Avoid immersing the site in water for 3 days. Restrict the affected arm for 12 to 4 hours, and you have to look into the diet pattern also. When we are placed with the primary pacemaker, permanent pacemaker, we will be having a card which contains the details of the company of the pacemaker which is implanted, whether it is single chamber or dual chamber, and it will have the do's and don'ts which should be followed and which should not be followed when the patient is having the permanent pacemaker. And intra-aortic balloon pump. This is because when the patient comes at the last stage of MI, they are not aware of the symptoms and they don't understand that it is MI. They can come at the last stage for the treatment. In that case, the patient may go to cardiogenic shock. So even doing the PTCA or the coronary angiogram will happen only through the support of intra-aortic balloon pump. So it is a mechanical device which will increase the myocardial oxygen perfusion, and it will indirectly increases the cardiac output through afterload reduction. So the IABP consists of a cylindrical polyurethane balloon that will sit in the aorta. You can see in the picture when the diastole it will expand and the systole it will constrict. So it is approximately 2 centimeters from the left subclavian artery. The intra-aortic balloon pump will be placed. So in case of, if you have received a patient to CCU in placement of IABP after PTCA, it is essential that the CCU nurse should be aware about the care of the patient with IABP. So she should monitor whether is there any infection for the patient. We have placed an equipment inside which may increase the infection level to the patient. And second, any hematoma and bleeding at the insertion site. The IABP will be placed only through the femoral site, okay? And then limb ischemia and monitor pulse, because when the IABP is placed, the particular lower limb should not be moved. It should be immobilized. So it may lead to ischemia. So it is essential we monitor the pulses of the patient. So the vitals of the patient to be monitored. The vitals will be, even in IABP machine, there will be ratio, triggers, and GCA should be assessed for the patient. The patient may go to any ventricular fibrillation, BT, even if the patient is on IABP. So we have to maintain the strict intake output of the patient, because the IABP is placed, there are chances the kidney can be injured. So the AKI can be early identified by low urine output. So it is essential to maintain the strict intake and output record. And next, observe the balloon catheter for presence of blood, which may indicate that the balloon is ruptured inside. It is very rare cases, and even in IABP, only helium gas is used. Even if there is balloon rupture, it will not affect the patient to the more level. Ensure the transducer, it should be flushed hourly 4 times and zeroed 4th hourly. Monitor for the signs of pulmonary edema and is there any ischemia. Infection and bleeding should be monitored. We should encourage the patient to do deep breathing exercises. As the patient will be on bed rest, it is essential as a nurse to provide backer to the patient to prevent the pressure ulcers. We have to hydrate the patient. We have to see the nutritional pattern of the patient. And it is essential to provide the psychological support to the patient who is on IABP. And next, if the patient has undergone angiogram in cath lab, they will be moved to CCU, the specialized cardiac ICUs after coronary angioplasty. Or if it is a triple vessel disease where the main LAD is more than 90% of blockage, PTCA cannot be a choice. So they will go with the CABG. So the cardiac CCU nurse should know the pre-care of CABG and also the post-care of the CABG for the patient. So CABG is nothing but the coronary artery bypass grafting, which is commonly referred as a bypass surgery. It is a surgical procedure that will redirect the blood flow around the blockage or a narrowed section in the major arteries, which will supply the blood and oxygen to the heart. So we have to know the CABG set. This is used in Apollo Main Hospital. These are the papers or the consents and the sheets which are used to know the pre-operative of the patient for CABG. Consent for CABG surgery to be taken by the doctors. All the consents should be taken by the doctors. Consent for the high risk, consent for anesthesia, and consent for blood and blood products. Forms which are to be filled by the doctors are pre-surgical orders, pre-surgical assessment by the surgeon who is going to do the surgery, an anesthetic record. The the anesthetist will come and visit the patient before going to CABG. Even it is emergency or the elective CABG, it is essential the anesthetist should monitor the patient. And clinical pathway, preoperative checklist, and surgical site surveillance. So the main investigation which should be done before CABG, the patient should have the HIV, HBsG report with them and blood grouping, because in CABG, if there is any blood loss, the blood transfusion should be done immediately. Then carotid Doppler and PFT. We have to provide psychological support to the patient and also to the patient attendant. The pre-op medication which are given as per doctor orders are injection TT, because to reduce the risk of infection with the bacteria that causes tetanus. Tablet Xyloric 150 mg will be administered to reduce the incidence of arrhythmias during the CABG procedure, and also to improve the cardiac performance and to reduce the markers of ischemia. The mupirocin ointment will be applied in both the nostrils with the cotton buds to reduce the infection. And tablet PAN 40 mg, in earlier cases, tablet Rantac was used. Now it is changed to tablet PAN to improve the gastric environment at the time of induction of anesthesia. And what are the preparation to be done for CABG patients are nilperoral, Chintudo preparation, billing clearance depending upon the hospital policies, chlorhexidine mouthwash, blood reservation to be done by the nurse, and lysowash bath. If it is emergency, we will be giving only before the moving to surgery. If it is elective, it should be given twice, the night previous day and the day of surgery. The pre-medication as per anesthetist is injection morphine will be given to reduce the anxiety of the patient before surgery. Injection Phenergan 12.5 gram will be administered. Both the morphine and the Phenergan, it will be administered through IV route to reduce the agitation and to increase the sedation effect. Before CABG surgery, room air ABG will be taken to evaluate the pulmonary function. So nursing diagnosis priorities are, first we have to reduce acute pain which is related to the decreased myocardial oxygen supply, ineffective tissue perfusion which is related to myocardial damage, inadequate cardiac output and potential pulmonary congestion, activity intolerance related to fatigue, anxiety because they will be perceived threat to death or any possible life changes will be there. So we have to reduce their anxiety, and knowledge deficit regarding the smoking cessation, diet, medication, and also the procedure. We should assess for dysarrhythmias, heart failures, and extension of MA. So our nursing goals will be attain adequate pain control, maintain the tissue perfusion, and expression of sense of well-being. Evaluation will be effectiveness of pain control, and skin color should be improved. So to decrease the workload of the heart rate, the interventions are pain relief, oxygen and morphine, bed rest, limit the visitors, avoid large meals. First, we will be trying with the liquid. If the patient is okay with the liquid, it will be changed to semi-solid or soft solid and then to the normal diet. Oxygen supplement depending upon the patient's saturation. If it is more than 94%, the oxygen is not administered to the patient. So complete bed bath, commode, avoid straining during the bowel movements, or music therapy, relaxation taps. Watch for any arrhythmias because even after coronary angioplasty, the patient may develop BT or BF. So we have to, the patient should be monitored particularly for the rhythms. Provide emotional support and spiritual care. So myocardial revascularization CABG preoperative I have explained in the slides. So preoperative teaching to the patient, to the procedure, we can explain through the video of surgery. We can give them the knowledge. ICU post-op, pain medication. We should explain everything to the patient before they are going to the intervention to reduce their anxiety. Chest tubes, endocardial tube. We should explain them that you will be 2 days in ventilator support where you cannot speak. Everything should be explained to them. Foley's catheter, emotional and spiritual support to be given. So patient after CABG, they may stay in ICU for 1 to 2 days, or they may enter to 3 to 6 hours after surgery, depending upon the patient condition. We have to assess the post-operative pain, administer the ordered pain medication. We should assess for cardiac tamponade. We should maintain the electrolytes potassium because when potassium is less or potassium is high, it may lead to the cardiac dysarrhythmias. Assess for dysarrhythmias, the atrial fibrillation, which is the most common. And chest tubes should be done. Milking of chest tube, Q first 1 hour or 2 hours early. Assess the amount and color of the drainage. So regarding chest tube, assess the respiratory status closely. Check water seal for bubbling. Milk not strip every 2 hours. Assess the color. If there is any color amount or the amount of drainage is increased, it should be immediately notified to the doctor. Steroid gauze and occlusive dressing at the bedside. So complications of MI, as Dr. Deepak has explained earlier, dysarrhythmias, cardiogenic shock, myocardial rupture, LV aneurysm, pericarditis, venous thrombosis, and psychological adjustment for the patient. So thank you for opportunity and sorry for making interruption in my slides.
Yeah, thank you, Sabri. It's an excellent presentation. I think you have covered almost all the points what is being required from the nursing perspective. So we'll take a few questions. So one of the questions it is asked by the Jude basically. So he wanted to know, or he wanted to explain you how what is this trans band, how it helps in a post angioplasty patient, and how long it should be used, and what is the mechanism of the band. So it is a very important aspect. Can you just elaborate on it?
Yes, sir. Sure, sir. Regarding the transradial band which we are using, after the procedure is over, they will be moved to CCUs. For 4 hours, the radial band it cannot be removed. So after 4 hours, we have a particular syringe to remove the air which is placed in the transradial band. So for first 15 minutes, 2 ml of the air will be removed from the transradial band, and we should assess whether there is any ooze at the site. If there is ooze, we will again inject 4 ml of air into it. When we remove 2 ml, if there is ooze, we will insert again 4 ml of air into it, and we will wait for another 30 minutes. And then we will take a trial of other 2 ml of air will be removed to check the is there any ooze. So like this for 15 minutes gap, after 2 hours, the whole air, which around 14 ml of air will be there in the transradial band, it will be removed. And after the full removal of air, the patient from the transradial band, after half an hour, the transradial band will be removed from the patient, and they can move their hands normally. We don't need to put any dressing on that side. Whereas in case of the Dynaplast dressing, for at least for 24 hours or 12 hours, the bandage should be, the Dynaplast dressing should be there in the hands, which may cause the infection for the patient, or while removing Dynaplast dressing, they may develop any skin peel. Whereas in transradial band dressing, there is no skin peel. We can assess whether there is ooze. It will be a plain plastic, so we can easily visible whether is there any bleeding or not. Whereas in Dynaplast dressing, it is not easily visible as it has gauze dressing and covered by the Dynaplast dressing. Whereas in transradial, it is easily visible.
Yeah, absolutely right. So hematoma is one of the important complications after any procedures like angioplasty or any kind of intervention which needs femoral access or radial access. So what is your views on patients who have been undergone angioplasty on the transfemoral route instead of the radial route? What is your protocol, and how do you check for the hematoma and manage it if the patient develops hematoma in the femoral route?
So for all the patients, whether it is radial or femoral, we don't differentiate this. We give equal importance for both the radial and also the femoral site. So if the patient is shifted to ICU with the arterial sheath, whether in radial or femoral, the doctors, depending upon the doctors, they may ask for clotting time. We should be done, and when it is less than, according to the heparin level which they have given at the cath lab, they may fix a clotting time. So after, when it is reduced the clotting time, they will advise for the sheath removal. So while removing the sheath, it is essential that the patient's blood pressure should be monitored and heart rate should be monitored mandatory, because they may go vasovagal during the removal of arterial sheath from radial or femoral. They may go vasovagal. So the emergency medicines like atropine, adrenaline, everything should be at place. So after the sheath removal, we will be giving a tight puncture to the patient. If it is radial, it will be around 15 minutes. The special puncture will be given for the patient to reduce the ooze. And after there is no ooze, the rhinoplas dressing will be applied. And if in femoral site, the tight pressure will be given for 30 minutes, and after that a tight dressing will be placed. So we have a special chart called pressure monitoring chart. So first 15 minutes, for first 1 hour, every 15 minutes, the blood pressure of the patient will be monitored and the heart rate will be monitored to identify any bradycardia or any vasovagal reaction. And the site will also be monitored for any ooze. So first 1 hour, every 15 minutes it will be done. And next, after 1 hour, half an hour, one will be assessed. And for the next 1 hour, half an hour. And after the 3 hours, they will be monitored every hourly, both the site and the vital signs of the patient. So first 3 hours is considered very crucial to assess any ventricular rhythm changes. Everything will be assessed in the first 3 hours. We don't have any differentiation of femoral or radial. Both are considered as equal, and we assess them equally.
Okay, thank you. Thank you for the elaborative talk. Any other questions can we have from the audience so that we can discuss? Or if there is no questions, can you just tell what are the other common complications you have encountered? My question is to Sabri in a clinical practice where the patient has undergone any angioplasties.
Many complications which we have assessed when seeing patient is, one is vasovagal. Even after sheath removal, if after 2 hours or 3 hours of procedure, they may be stable, and after 2 hours, 3 hours, they may go to vasovagal. And second one is the cardiogenic shock. So it can be earlier identified by low urine output of the patient and decrease in the blood pressure of the patient suddenly. So low urine output is cardiogenic shock is the second one. And third one is the pulmonary edema. Even during the procedure of PTCA, the patient may develop pulmonary edema at the in the cath lab itself. So it will be treated with injection Lasix and by connecting of NIV. So there are cases where the patient will coming to emergency, they will be stable, and in the cath lab during the procedure, it may be before the balloon or after the balloon, they may develop pulmonary edema. So it is essential to monitor the pulmonary edema, and rare cases of aortic dissection may occur. And if the patient is very cardiogenic shock is there, compulsory the patient will be on IABP while doing the angio or PTCA. So our responsibility increases when the patient is on the IABP. And the post-procedure of PTCA, the patient may go to bradycardia. Heart blocks are very common after the procedures. So as a complete, we have to, as a cardiac nurse, we should be aware about every equipment which we are using for the cardiac patients. It may happen at any time, not only in 12 hours or 24 hours. It may happen at any time. So while shifting the patient to ICU to the ward, we should specifically inform about the patient's events that happen in cath lab and also in the ward to monitor the patient for till the day discharge.
Okay, very good. I think most of the points are being covered, and I think we are now almost done with the discussions and the talk. So with this, I would like to thank all of you. If there is no more questions, we can wind up. And I really thanks to all the stakeholders of the Apollo Center of Excellence in the Critical Care. And these webinar sessions are quite encouraging, and it's always impart us and enlighten us with more and more knowledge to every clinical practitioner. So special thanks to Mahajan sir, Jude, and others who have actually taken the burden of starting this series of webinars from my side and from all the Apollo family. So with this, I think we can conclude. And thanks to both the speakers, Dr. Deepak and Sabri, they have actually elaborated in a very nice way. I think we can conclude if there is no more questions.
Thank you very much indeed. Thank you.
Yeah, thank you all of you.